Vaginismus is ruining sex everywhere. It's time to wake up, India. Hi, my name is Dr. Surakshith Battina. I'm an endoscopic surgeon, a fertility specialist, and a cosmetic gynecologist working at Indigo Women's Center, Chennai. And in today's video, I'm going to give you guys a brief explanation about vaginismus, what the possible causes, and probably what are its treatment options. It is assumed that around 6 to 12% of women around the globe suffer from vaginismus. Unfortunately, it is still an assumption because you and I very well know how hush-hush it is in India to talk about sex. And more importantly, if you go and bring this situation to your gynecologist, both you as well as the gynecologist both are uncomfortable in talking about intercourse. She's not going to do any examination on you, but rather ask this question: how old are you? Because in India, it is still unacceptable for younger women to have sex. The textbook definition of vaginismus is the feeling of pain every time a woman thinks or has an insertion. So this insertion can be anything. Sometimes it can be sexual or non-sexual. Sexual if in case it's going to be a penile insertion, and non-sexual if in case she's going to have even a gynec examination, or also if in case she's having a tampon insertion. It's very difficult to pinpoint exactly what might be the cause of vaginismus, but in general it can be psychological, relational, or even cultural. They say a picture is worth more than 1,000 words. So in my opinion, vaginismus is 33.3% physical, 33.3% interpersonal, and 33.3% intrapersonal. It is again a diagnosis of exclusion. For example, if in case the patient is having inflammation, or she's having some kind of trauma or infection, or any other reason which might be a cause for this pain in the vagina, once all of them are ruled out, only then you have to come to the conclusion of vaginismus. When you go to a gynecologist, you think that you're the one who's going to be quite embarrassed talking about sex and intercourse, but trust me, it's not just you. Even the gynecologist who's actually sitting on the opposite side listening to all this can sometimes be uncomfortable talking about your sexual issues. The reason is because not many gynecologists are sensitized in this matter, and I would definitely suggest all the doctors, at least the upcoming doctors, to go ahead and try to get an understanding of cosmetic gynecology. Get desensitized about most of these issues before going and sitting in the OP. The gynecologists are a little bit younger, are more open to talking about sex and sexuality. The more senior gynecologists may not be very comfortable with this whole topic. So try to look at the credentials of the doctor, see if they have some kind of training in cosmetic gynecology, and if you go to them, the chances are you're going to get a treatment for your vaginismus. The challenge in vaginismus is that the moment there is some kind of penetration or a thought of penetration, the muscles around the vagina, which we call as the bulbocavernosus muscles, they tighten up. The patient has some kind of excruciating pain. So the moment she has pain, again, this starts out with fear. The fear of penetration. This becomes a vicious cycle. So the more and more she's having this, the more and more trauma it increases, and finally this just makes her hate having any kind of sexual intercourse. Psychologically, it is going to be affecting you at a very deep level. So ideally, you understand you have vaginismus. It's always best to go and seek treatment immediately. Vaginismus has 4 levels depending on how severe the symptoms are. I'm not going to really tell you more about it, but as all levels go, level 1 is the least severe and level 4 is the highest of severities. Vaginismus can be primary or secondary. Primary if in case she has been suffering from this throughout her life. Secondary if in case the woman had penile penetration or some kind of penetration earlier, but for the past 6 months she is unable to have intercourse because of this pain what she feels in the vaginal area. This actually reminds me of one particular patient I had who was around 31 years of age. She was happily married for the past 6 years. She had never ever had sexual intercourse. So for this particular patient, I have given her a treatment option of going ahead and trying various modalities, which I'm going to explain to you in the next few minutes. But then she said, no, I really cannot understand this whole phenomenon of having sex. It looks like she was kind of partly disgusted by this idea. Again, as I said, this has a lot of psychological as well as anatomical aspects, so both of these have to be looked into carefully before we go ahead and give treatment for these patients. This particular patient still got pregnant because we had to go ahead and use a procedure called as the intrauterine insemination under anesthesia, where basically we take in the sperm from the husband, we prepare it, and then we put it directly inside the uterus so the patient can conceive even without any kind of sexual intercourse. But then again, she was not a candidate for this particular procedure. The way we approach vaginismus has to change. It requires complete examination. First, by using the Q-tip, you try to identify whether the patient is having vaginismus or not. Also, figure out whether the partner has any other issues. And if in case there are no issues on both the sides, that is the external appearance of the genitalia look absolutely normal, that is the time we have to go to the next step. There should be multiple counseling sessions along with the couple. It's just not one session you're going to come to a conclusion, okay, this lady is having vaginismus, let's start the treatment. Along with these multiple counseling sessions, the patients might also require psychosexual therapy, they might require relaxation techniques, physiotherapy, and some patients might also require senate focus. Then you can try a combination of lubricants along with estrogen jelly. This works wonders for many women. Then they start off using dilators, from the smallest dilator slowly increasing up to the largest dilator, and once she's comfortable using the largest dilator, after that she should be able to go and have sexual intercourse with her husband. Personally, I'm not a big fan of using anxiolytics, though I've seen a lot of patients who have used them, but I don't think taking medication to get rid of this vaginismus is a very good idea. I use Botox. We numb the muscles, this bulbocavernosus muscle which I've talked to you before, and under the anesthesia, I find this muscle and I inject Botox into this muscle, so the moment I inject it, it becomes relaxed, and she wakes up with the dilator inside her vagina. She feels kind of confident. She's like, okay, I'm able to bear this. Definitely I will be able to go ahead and bear even a penile insertion. So for the next few weeks, you go ahead and try using the same dilator what is inside. Then I give her a couple of other sizes of dilator as well, and once she's okay, maybe 3 or 4 weeks down the line, she should hopefully go ahead and have sexual intercourse. I have never seen such patients where Botox has actually failed therapy. There is a last option what they can do. This particular procedure called as the vulvar vestibulectomy. This is a bit of a morbid procedure. I hope I'd never get to do this, because me being a cosmetic gynecologist and I believe in vulval harmony, this procedure I'm not a very big fan of. Just like anxiolytics, I'm not a very big fan of vulvar vestibulectomy too, but if there is a patient who is resistant to Botox, then that probably becomes our last option. Thank you all so much for watching this video. Leave a thumbs up if you got some good information, and if you have any other queries about vaginismus, feel free to leave your comments down below. Make sure you subscribe to my YouTube channel for more such informative videos, and until the next one guys, have a good day and I'll see you in the next one.